Hi, I'm Ken Ben Muller. I'm the Director of Interventional Endoscopy Services at California Pacific Medical Center in San Francisco. I'd like to provide an introduction and overview of our paper entitled Suck Ligate Unroof Biopsy, called SLUB, by using a detachable 20 millimeter loop for the diagnosis and therapy of small subepithelial tumors. A few words of background. We see subepithelial tumors every day in our practice, but these can be challenging to diagnose and treat. In terms of diagnosis, endoscopic biopsies rarely reach the tumor. Diagnostic EUS narrows the differential, but it has limited specificity, and EUS FNA can be technically difficult when these lesions are small and mobile, and the samples can be very scant or provide no yield. The sets can be challenging to treat using either a snare or submucosal dissection. There's a significant risk of bleeding and perforation. This chart here compiles some of the studies, and you can see there are perforation rates as high as 13%. This is actually a sequel to a previous paper of ours entitled Retract Ligate Unroof Biopsy. So the principle of the technique is the same. This technique was designed, the RLUB, Retract Ligate Unroof Biopsy, for large non-pedunculated stromal tumors. Let me first show you how that procedure is done, because it's basically the same technique as the SLUB. So with a larger lesion such as a GIST, we use a double channel scope and we retract the GIST lesion into the open endoloop with a three-pronged anchor. And we retract the GIST until the ball wall inverts so that we can place the loop well below the GIST at its origin from the muscularis propria. Then we unroof the mucosa overlying the tumor with a needle knife, and we do a cross incision to maximally expose the underlying tumor. Now we can obtain our biopsies, and we can obtain generous samples for immunohistochemistry and calculation of the mitotic index. With the SLUB technique, we are substituting the retraction with that grasper with suction. And we can generate very powerful suction using the cap attachment. This is the 18 millimeter soft oblique cap. You're probably already familiar with this from the cap EMR technique. But instead of deploying a crescent snare along the rim here, we are deploying a 20 millimeter loop. Now here you can see the standard endoloop, it's 30 millimeters. This is a smaller endoloop, it's 20 millimeters, and it's smaller to fit along that rim of the oblique cap. Now the technique. First is the ligation. This ligation is going to strangulate off the blood supply to the tumor. This results in ischemia and eventual tumor ablation. We unroof the mucosa overlying the tumor, and that enables us to obtain biopsies. The unroofing also contributes to the enucleation of the tumor. By performing the ligation before the unroofing, we avoid bleeding and perforation. This is the technique shown in 4 steps. First, the suction to draw the set into the cap. So here we have our oblique cap, 18 millimeters in diameter. Our loop is aligned along the rim, and we apply suction until we get basically a red out. We have the entire tumor inside of the cap. We then deploy our loop, we tighten the loop, and it will be well below the set, and we can confirm that using a catheter mini probe with endoscopic ultrasound. We then unroof the overlying mucosa with the needle knife, and we do a cross incision to maximally expose the underlying tumor, and then we obtain our biopsies. Sometimes we actually enucleate the tumor. It's not intentional, but as we pull to obtain our biopsies, because these lesions are fairly small, they will sometimes spontaneously enucleate. Our study design, it is a retrospective study, but it's a prospectively collected computerized database. The inclusion criteria were intramural sets all less than 20 millimeters in size, measured on EUS. We excluded all lesions that had typical features of a lipoma, a varix, or a cyst. Of course, these are lesions that we do not need to treat. Next slide. Now, after our procedure, we submitted our specimens for histopathology, immunohistochemistry, and, if applicable, a mitotic index, for example, the GIST lesion. And then we followed up with an endoscopy and EUS at 3 to 6 months. Here are results. 23 patients, 24 tumors. Most of these patients had sets diagnosed as incidental findings, often with complaints of abdominal pain, but 2 patients did have bleeding and 2 had dysphagia. The tumors were located throughout the GI tract, mainly in the stomach, but we had some small bowel, colon, and rectum. The mean size was 10 millimeters, ranging from 6 to 15, and the median procedure time was 15 minutes. Now, we were able to obtain adequate samples on all of the patients, as well as immunohistochemistry. We had 8 leiomyomas. They all had CD117 negative and SMA positive immunohistochemistry. We had 5 GISTs, 5 carcinoids. We had 3 pancreatic rests, 2 Vanix tumors, and 1 granuloma. We had post-procedural pain in 2 patients. This was self-limited. We had no bleeding and no perforations. 13 of the patients had follow-up. Those were all patients with lesions that had some cancerous potential, such as carcinoid and GIST. There was no residual tumor on follow-up of any of these patients that had follow-up. Next slide. The limitations of the study are that it was retrospective. It was done at a single tertiary center at California Pacific. The sample size is small, and we have limited follow-up on these patients. In conclusion, this 20 millimeter loop ligation of small non-pedunculated sets was found to be feasible using this 18 millimeter cap attachment to suction or to draw the tumor into the cap itself and place the ligation, the loop, below the tumor. Unroofing after ligation was found to be safe, and it provided sufficient tissue for immunohistochemistry and, when applicable, for a mitotic index calculation. The strength of this procedure is that it enables diagnosis and potential cure in a single procedure. But the weakness is, of course, we don't have a en bloc specimen to submit to surgery. We don't have the surgical pathology. But we think this is mitigated by the fact that these small sets are usually benign. Even when a GIST, the likelihood of a high mitotic index is extremely low. And we have endoscopic ultrasound to confirm the ablation of the tumor afterwards. Thank you very much.